So what do you notice in this ECG? So the history is already written for your reference as well. 26-year-old asymptomatic, but once you try to auscultate, you notice this. There's a heart murmur. So in the ECG, is it a? How about the rate and rhythm? Is it a tachycardia? Is it a sinus or not sinus? So we notice it is a sinus rhythm ECG, and heart rate is slightly in 90s. Yeah, agreed. How about the axis? It is right axis deviation. Then looking at the P wave, it is tall P waves. Yeah, so this is right atrial enlargement. Good. How about the V1, V2 if we notice? Right ventricular hypertrophy, right? Similarly, if we look in the V1, R' pattern. And in the inferior lead, something interesting. Crooked sign, as I said it. So what it is? Crooked sign with right axis deviation. Ostium secundum. Okay, let's move on to the next ECG. 40-year-old male with heart murmur. Is it sinus rhythm or not? It is sinus rhythm. Then axis is right axis. Similarly, P pulmonale is there, so right atrial enlargement. And looking at the V1, right ventricular hypertrophy. So what does it show? ASD with Eisenmengers. Another patient, ECG in front of you. Come on, rapid fire. Quick, quick, quick. Sinus rhythm is there. Axis is left axis. What else do we notice? Right atrial enlargement is there. How about the PR intervals? You can call it like a trifascicular because there is a right bundle branch block with left axis deviation, and PR is also slightly prolonged actually. Yeah? And there is right ventricular hypertrophy as well. And you do notice there's a R' pattern in the V1. So what does it point out to? ASD. But Ostium Primum. How about this young guy? What do you notice in this one? Okay. So what do you think? What do you think? Come on, have a look on the ECG at the steps which I had said it already. So what do we notice? It's a young guy. I already give you the hint. It is, of course, congenital heart disease. Isn't it? It is sinus tachycardia. We can see the P waves in front of all of those cures. Axis-wise, right axis deviation. How are these P waves? Because the patient is in tachycardia, so it can be a little bit difficult to say, but right atrial enlargement is there. Yeah. Then by looking at the V1, there is right ventricular hypertrophy, right? Then we look at the V5, V6. What does it further say? LV volume overload. Okay, so what is that sign? Katz-Wactel phenomenon, which is characteristic for the VSD. So biventricular hypertrophy is there. So what does it mean? Biventricular hypertrophy with right atrial enlargement. There is large left to right shunt with high pulmonary vascular resistance. Yeah. What is happening over here? So is it sinus rhythm or is it something else? So this is sinus rhythm, yeah? How about the axis? Again, a right axis deviation. By looking at the V1, V2, any hypertrophy, you would say this is right ventricular hypertrophy, right? And as we already noticed, there is monophasic R wave in the V1 and S wave, especially if we look in the V6, there is reduced amplitude of S in the V6. So what does it mean? This is VSD with Eisenmenger, right? Let's make it a little bit simple twist. This is a ECG. We have already given you a big hint. You can look something in the V1, the V6, deep S wave in V1, and tall R wave in V6. So it is left ventricular hypertrophy criteria. Rest, axis wise, it seems fine. Rest all is good. So what should you think of? Coarctation of aorta. How about this 45-year-old lady with the exertional breathlessness and a ejection murmur? I'll give you a hint. I am a nice person, isn't it? So these two areas you should try to focus upon. People say to me that I'm a super nice person. So I'll try to show you my super niceness. How? I'll give you one more ECG. Another 25-year-old but cyanotic. I'll show you my extra generosity. How? You can comment about the pulmonary blood flow. What do you say? So if you look carefully at the ECG rhythm-wise, the patient is definitely in sinus rhythm, isn't it? Axis-wise is right axis deviation. By looking at the V1 itself, we can say it is right ventricular hypertrophy. However, we notice that, for example, from V1 to V2, the R which was more prominent in V1, becomes less prominent compared to the S wave. So transition tends to happen around V2. Similarly, the adequate amplitude of R and T waves in V5, V6 leads. Yeah, that's what. So, what does it mean? There is moderate pulmonary blood flow, which is characteristic of Tetralogy of Fallot. So, what is happening over here? 1-year-old cyanotic boy comes to your clinic with this ECG. Since I'm super nice, I'll give you one more ECG now. And some hint as well for you. What is happening? So, what do we notice? We notice, see, even there's something written over here as well. You can take some inspiration from that. There is again sinus rhythm with right axis deviation. P wave seems to be pretty normal, right? And then while looking at the V1, V2, it seems like a right ventricular hypertrophy, yeah? But in V5, V6, is there any Q waves anywhere? Yes. So what it is? PDA with Eisenmengerization. What about this neonate? Neonate with cyanosis and dyspnea. What is happening over here? There is sinus rhythm with right axis deviation, a right atrial enlargement with right ventricular hypertrophy, and Q wave is present in 1 in AVL. So what do we notice is DURV with subaortic VSD and pulmonary stenosis. Another neonate with cyanosis. The ECG is in front of you. This is again sinus rhythm, right? And axis is left axis deviation. And looking at the P waves, right atrial enlargement, any comments on the chamber hypertrophy, left ventricular hypertrophy, right? And the patient is cyanosed as we are already aware, so it is tricuspid atresia. How about this ECG? Are the changes similar to the one which we already spoke about? Here, definitely, this right atrial enlargement is quite a lot pronounced, I would say. Quite a lot pronounced, especially if you notice. So, this is the same case of tricuspid atresia, but in another patient. A grown up young boy with palpitation. Sinus rhythm, yes, but how's the P waves? They are very tall but widened as well. So, what is called as Himalayan P waves? And there is multiphasic, low amplitude, bizarre QRS complexes with multiple deflections. Yes, And you do notice prominent Q waves in the right precordial leads, which is again characteristic of Ebstein's anomaly. What do you notice over here? How are the P waves? And where are the Q waves? Do you notice any Q waves? So they are like the similar case like earlier one, isn't it? So that was again a Ebstein's anomaly. What about this guy? 35-year-old female with giddiness. Come on, use the chat box. You know the diagnosis very well. There is left axis deviation. PI interval definitely seems like slightly on the higher side, yeah. And in V1 to V6, there is Q waves as well, but it's not there in the V5 V6. Yes? And the T waves are very prominent. So what is the diagnosis which I had said it earlier itself? CCTGA. So sorry about the poor quality of this ECG, but what do you notice over here? Look at the rhythm strip. It will give you some interesting insights. This is an old, young patient itself, pretty young. You notice like P waves and QRS waves are not correlated. But how's the QRS? It is narrow. In the left precordial waves, there are tall R waves. Newborn with such ECG. So, complete heart block in congenital complete heart block. So the key thing which we all should remember is that yes, one in like 2,500 to 20,000 live births, yes, it can happen, especially if there is a maternal history of maternal SE, otherwise NTSSA or NTSSB autoantibodies, and it is significantly associated with the congenital heart defects. In fact, 90% of the newborns with isolated congenital heart blocks can have long survival. Okay? This is a patient which is asymptomatic. So, what do we start noticing? I want to give you time at least of 2 minutes. Think about it and tell me. See, I'm not interested in the diagnosis. It's okay. It doesn't matter if you don't tell me the diagnosis, but at least tell me the findings. What do you notice? This was a young female patient who had just come for, for her routine checkup and all. She didn't have any problems. And you did the ECG and you came across this. Is this ECG fine or anything would you like to say? So what do we notice? In this we can see this is the again in patient is in sinus rhythm. The axis is right axis deviation. However, in one in AVL, if you notice there is a positive and negative QRS. It is negative QRS. And AVR, it is positive. So a lot of times someone may think that there may be lead reversal, but there is no lead reversal. Okay? In fact, if we try to look at the left precordial leads, there is progressive reduction of the RS amplitude. So this is an example of levocardia or dextrocardia. So definitely dextrocardia. Okay? That's why I was telling one can even think of lead reversal. But with situs inversus. Okay? So I hope you were able to understand. So as I said it, see, no one always expects you to be able to make the correct diagnosis because there are a lot of other tools which is available for making the correct diagnosis. What at least is expected is to be able to approach the ECG in a good way. So that is what is the most important thing. Rest, everything else can be done. Okay. So I thank you all for your kind attention.